Now, folks, it looks like we're going to have to change up a little bit. Uh, I believe we're going to have to get Dr. Sasson, Dr. Aaron Sasson, up for his presentation. Dr. Zach's is delayed, and we'll put him on instead of in this slot, then right after Dr. Aaron Sasson speaks. Dr. Sasson, are you there? Can you turn on your mic?
Yes, I'm here.
Very good. Very good. If you want to, are you ready to do your presentation?
As long as, yep, get my slides up and I'll be ready to go.
Yeah, no problem. We got a brief survey up there, and then we're going to put up your slides, and we're ready to go. Thank you. Thank you for being here today as well.
Of course, thank you for having me.
Yeah, and okay. So you've seen Dr. Sasson up here, and basically he's at Stony Brook University School of Medicine on Long Island in New York. He specializes in the treatment of upper GI tract tumors, liver, pancreas, esophagus, stomach, uh, and especially in carcinoid, pancreatic, NETs, and adrenal tumors, and Whipple procedures, which is a very arduous procedure, I understand. Without further ado, Dr. Sasson, it's all yours.
Thank you very much. Thank you all. Thank you for inviting me, and I'm happy to be here speaking. I'll go ahead and begin. I have no disclosures and no conflicts regarding this presentation. And I know an overview was done previously, and I know many of you know this, but obviously just to recap, the majority of the neuroendocrine tumors occur in the GI tract, and the majority of those tumors probably then occur in the small intestines and in the pancreas. And for the most part, I'm going to limit my talk on discussing small bowel neuroendocrine tumors as well as pancreatic neuroendocrine tumors. I'd be happy to field questions regarding gastric or other sites as well. And I know there was a question earlier on a gastric carcinoid, which we can revisit during the Q&A as well. It's so important. This is the one slide that to me is everything with regards to neuroendocrine tumors. If you cannot classify the neuroendocrine tumor properly, then you will be unable to deliver the appropriate therapy. And if you're the patient, you will not receive the most appropriate therapy. So there is nothing more important than having a complete pathology report. If the biopsy is inadequate, then we repeat it. We don't guess. We cannot take that chance. It is vitally important to obtain the correct pathology report, to have all these features in with regarding to the grade, to differentiation, mitotic activity, and the Ki-67. And sometimes it's even worth, there's a question earlier in the session today about getting a second opinion. And sometimes I think just having a pathology re-review the slides is probably one of the most cost-effective second opinions you can get, just to confirm that you're dealing with the correct tumor. Vitally important, all decisions are made about regarding this. And for today's purposes, I'm going to be talking about surgery with regards to the well-differentiated low and intermediate grade neuroendocrine tumors. So everything I'm going to mention is applicable to those subtypes. I like showing this slide because it has all the treatment options, for neuroendocrine tumors, ranging from observation to hormonal therapy, targeted therapy, all the way down to surgery. And what I use this as a teaching point for my residents and students and other faculty members, saying that if you have a condition where the treatment options are so varied, it tells you two things. One, obviously, that there is varying degrees of biology or aggressive behavior for these tumors, but also that we don't have one great option. For the treatment options for colon cancer, it would be two things: surgery when you can get it, and chemotherapy when you cannot. And if it's in the rectum, you get radiation therapy. Simple. But for neuroendocrine tumors, the treatment options are significant, and I'll discuss a little bit about some of these, but particularly surgery. Now, the next question someone's going to say, well, how do you determine who gets what? Well, the bullets on the screen on the right side or left side are the factors that help us: symptoms, hormone secretion, general health of the patient. If there are, someone who has a significant heart issues or had a stroke and is bedbound, that patient may not be fit for surgery. Also, the amount of tumor that they have, the degree of uptake on your radionucleotide test is a factor in determining what options you may have. And as discussed before, the histologic features about whether you're well-differentiated, low-grade, or intermediate grade. And then we also want to assess the biological growth. And although normally I don't take age into effect, this is one of the conditions where I do, and I'll discuss that with a patient example just shortly on in my presentation. The International Alliance for Neuroendocrine Cancer has the treatment goals as follows: remove the tumor, alleviate symptoms, control tumor growth, and probably most important, although last, not by any design otherwise, is to maintain patient quality of life. I think this is vitally important, as the surgery is a treatment modality that can be associated with complications, and I'll discuss some of those in a second, and it can really impact someone's quality of life. So I think all these things have to be taken into account, and it's vitally important that a adequate assessment is done to ensure that the patient is receiving the most appropriate therapy. Now, with regards to surgery, even though it's probably the most invasive of all the treatment options, it really is the only treatment option that affords the patients the possibility of cure. It is the first line option for patients with localized disease, or at least non-metastatic disease. And with regards to consideration of surgery, we have to look at where did the tumor start from, how big is the tumor removable, is it making hormones, are there any evidence of disease spread, what's the overall health of the patient, and what kind of risks are we dealing with for the surgery. All of these things have to be taken into account. And to be honest, at most centers, as was discussed earlier in today's session, these things don't occur in a vacuum. But at all the centers that have been discussing, including ours here, all this is done via a multidisciplinary team with a whole host of physicians who are experts in neuroendocrine tumors discussing patients. And I'd say that all patients are almost all get individualized treatment. So it will be difficult to lump patients at times, but it is important that they receive individualized options because of the multiple factors involved with regards to their treatment choices. Dealing with metastatic disease is also important. Surgery is possible to help with metastatic disease, although when patients have metastatic disease, curing them is frequently not possible, unfortunately. However, long-term survival is possible, particularly when a significant amount of the tumor burden can be removed. In patients who have hormonal symptoms, removing 80 or a significant portion of the metastatic foci or spread offers great palliation for patients. So it can be important. I recall one particular patient who had a metastatic functional VIPoma of the pancreas, a relatively uncommon pancreatic neuroendocrine tumor that results in 20 to 30 bowel movements a day, and she was unable to leave the house. We resected her spread to the liver, and she had her life again. Even though she was in her 80s, she was grateful that she can now go visit her grandchildren without worrying about where the next restroom was. The other point I want to make that one of the most next to pathology, the next most important factor is imaging. Having the right imaging scan is critical for surgical planning. Without it, you are lost. It'll be like driving someplace without a map or your Google or your GPS. We use a variety of imaging modalities, CT scans and MRI. And in the morning session, as in concordance with my opinion, we prefer MRIs more often than CT scans, particularly for the liver. MRI of the liver is far superior, not far superior, but is superior imaging modality than CT scan. Plus, MRI affords us the safety of no radiation. We do get CT scans of the chest because MRIs of the chest are very difficult to interpret due to the breathing. CT scans are much faster and not as claustrophobic, and that has that advantage. And clearly, there are also multiple somatostatin receptor scintigraphy that we can do. These are your octreotide scan, your gallium dotatate scan, and now most recently your copper dotatate scan. And so the scans that we see below are images. This is actually the same patient down here. PET scan on this panel, and a gallium dotatate here showing the liver lesion that was not seen on the PET scan. This is a patient who was referred to us. They had an octreotide scan and a PET scan prior to seeing us, and then we ordered a gallium dotatate scan, and you can see the vast difference in the pictures. You can see multiple foci of metastatic disease to the spine, lesions in the liver, lesions in the lymph nodes present here as well. And by far and away, I think gallium dotatate has been a transformative or revolutionary advance for the management of patients with neuroendocrine tumors, particularly when it comes to surgical planning. It allows us to detect lymph node metastases or liver lesions that may have not otherwise been seen. And of course, new is the copper dotatate scan, although I have no personal experience with that as of yet, although we are gearing up to start that here at Stony Brook as well. I should note that the gallium dotatate scan can be fused or done concurrently with a CT scan or MRI. At Stony Brook, our preference is to do it with an MRI. This way we can do a MRI of the liver at the same time and alleviate multiple scans. I'm going to focus just a little bit now on the small bowel. Everything I said before was applicable to both the small bowel and pancreas, but now I'm going to talk about some of the specifics that are different with regards to the small bowel neuroendocrine tumor, otherwise known as carcinoid. Obviously, we all know that there's a delay in diagnosis, and the question before my talk was pertaining to that. It's also noteworthy that 20% of patients have multiple tumors, more than one small bowel carcinoid tumor. Now, it is difficult to see these tumors in the small bowel, and most patients are diagnosed when they have a mass in the mesentery. This mass in the mesentery is a conglomeration of lymph nodes, and I'll show you some pictures of those and why that occurs. And why, and I'll even explain as to why that's the site that's detectable. Now, the problem with this mass in the mesentery is that it causes this fibrosis or this desmoplastic reaction, and I describe it as being sticky. Normally, your intestines are in your belly and they're free floating. They move around. They move around with ease. But when you have carcinoid tumor, particularly in the lymph node, that makes it sticky. And so other bowel, adjacent bowel will stick to this lymph node mass and won't move. And because it won't move, you're now at risk of developing bowel obstruction. And it's because of this stickiness that when it comes to surgery for small bowel carcinoid tumors, if they have large, bulky lymph nodes in the mesentery, I will almost certainly not do this laparoscopically. Laparoscopy or minimally invasive type surgery is useful modality for some patients who may have very small or carcinoid tumors found by accident, It's like someone's getting a colonoscopy and they found a small 1 centimeter tumor in the ileum with no evidence of any lymph node metastases on a gallium dotatate scan. That person can undergo a laparoscopic resection. But if they have bulky lymph nodes, it is too difficult. It is a difficult operation to do even open, let alone laparoscopically. And I personally think it's dangerous, and we prefer to do the open operation. If patients have advanced disease, we always remove the gallbladder, as patients who are often going to be receiving somatostatin analogs. They are notorious for causing gallstones or gallbladder dysfunction, and we remove the gallbladder routinely on such patients. So the difficulty with the carcinoid tumors is that they exist for quite some time before they're diagnosed. This shows that the patients having vague abdominal symptoms, often diagnosed as irritable bowel syndrome, and it may take almost 8 to 12 years before there is an accurate diagnosis. And I'll be curious to see the results of the survey, but I'm sure they're going to parallel what's been published before. This is a slide that was recently published showing that the number of doctors a patient had seen was 6 prior to getting a correct correct diagnosis, and the number of visits that the patients went to was almost close to 12. So average patient will see 6 different doctors with regards to this before a correct diagnosis, and up to 12 visits just to get it right. So a significant delay in the diagnosis. And unfortunately, IBD or irritable bowel syndrome or irritable bowel or inflammatory bowel disease are the most common mistaken diagnoses for this tumor. And the average about 5 to 7 years in this study from Dr. Pommier. Now, this is a difficult concept, and I want to take just a little bit of time showing you. This is what your intestines look like. This is your large intestines, this is your appendix, and this is your small intestines, all bunched up inside your abdomen, freely moving around. And this is what it looks like when we stretch the intestines. So your intestines are on this fan-shaped structure here, filled with fat. There's fat and the blood vessels. It's hard to see on this picture, but this is when it's opened up and stretched out. Now, in this fat, this is where the blood vessels that supply the blood to the intestines and then take the blood away from the intestines. And we have lymph nodes all over our body, thousands of them everywhere. And lymph nodes like to live next to lymph nodes like to live next to blood vessels. So this is where the carcinoid tumors spread in this fat here. And this is why we can detect them on CT scans, because we know that there's not supposed to be anything in this fat, whereas the tumors are on top of the intestines, and it can be very difficult to see. An important point, and the difficulty is in this picture. Here's a depiction of a small bowel carcinoid tumor. Here's a depiction of the lymph nodes. Now, if the lymph nodes are really close to the intestines, the amount of blood vessels involved is very low, is very small. But as the lymph nodes travel or spread to the arteries that are larger, it becomes more difficult, and you may have to remove more intestines in order to get out all of the lymph nodes that are involved. This is a picture. This is a special kind of a scan. This is showing, this is the mesenteric or the lymph nodes that I just described, and each one of these dots is a tumor. This patient had 21 small bowel carcinoids, all in the same area. All of them had to be removed. I'll switch a little bit now to pancreas surgery, and everything. And for the most part, the points I described earlier are pertinent to pancreas, with 2 exceptions. One is we have to take into account the genetic aspects of pancreatic neuroendocrine tumors, and we treat patients who have a hereditary form of pancreatic neuroendocrine tumors a little differently than those that do not. The ones who have a hereditary form, either MEN, von Hippel-Lindau, or even neurofibromatosis type 1, have typically less biologically aggressive tumors. Furthermore, pancreas surgery is associated with some significant risks. It's not easy operating on the pancreas. There's a fair number of complications. Now, most patients may not have the same amount of delay as those that have it for small bowel neuroendocrine tumors, but it's still vitally important to listen to your patients. This is a patient who came to me. She had a glucagonoma, a functional neuroendocrine tumor, about 20 years prior to seeing me. She came back to see me and said that her tumor has recurred. And I asked her how she knew that since she didn't have any CAT scans. She lifted up her shirt and said, "There's my tumor." I said, "You're right, the tumor has come back." And we went and go ahead and got a CAT scan that showed the tumor, and we resected her and helped her with her symptoms. With regards to surgery on the pancreas, there is nothing more important than location. Tumors in this part of the pancreas, known as the head, often will require a Whipple operation. Tumors in the body of the pancreas will require something called a distal pancreatectomy. If the tumor is small and accessible, you can just carve it out as well. However, determining what kind of operation is dependent upon location as well as the imaging studies. So the two most important things. Now, many of these things can be done laparoscopically or robotically. And so I think that's been a big boon for patients, is our ability to do these operations with with minimal scarring and faster recovery. I've also learned not to show surgery photos right after lunch, so I did not. But I wanted to show what we do or how we use a new modality, robotics, in the operating room. If we can play the video, that would be wonderful. It's a quick video. And these are some of the tools that we have available. They're sterile, of course, and allows us to do very fine precision work. Here it is a robot being controlled by a surgeon, peeling the skin off of a grape. And here it is, the surgeon suturing the skin back on. Now, this permits us to do very fine, delicate pancreas surgery. It has been adopted by us here at Stony Brook very successfully, as well as others. What to do about this is probably one of the most frequent things I see in my office nowadays, and that is a patient who presented with appendicitis, and during the course of the scanning for appendicitis was found to have a small neuroendocrine tumor in the pancreas. Typically, when they're small, we can watch them. If they're larger, we typically offer them resection. But this is where other factors come into play.